So good evening, everybody. So we are here for the PG case discussion Bodhana conducted by TNFOG. And good evening to Dr. Anjalakshmi Madam, who is our President TNFOG, Founder President, and Dr. Sampath Kumari Ma'am, Founder Secretary TNFOG, our President Dr. Ramani Ma'am. So good evening to all the members and the presenters today. I welcome all the examiners, Dr. E. Shanti, who is a professor of Department of Gynae, Savita Medical College Hospital, Chennai. And she has done her MBBS from Madras Medical College and MDOG from IOG. And she's trained in ultrasound and obs and gynae, advanced infertility, advanced laparoscopy. She's also provider and instructor course. And she's got more than 25 publications. And a field of interest are endoscopy, high-risk pregnancies, and adolescent gynecology. And she's an examiner for undergraduation, post-graduation exams. And she's an invited faculty in conferences. And she's organized national, international conferences. I welcome Dr. Parimala Madam, who is an Assistant Dean, Savita Medical College. She's been a Dean between 2018 to 2022. She's a HOD Academics Department of Obs and Gynae, Professor and Unit Chief, Savita Medical College and Hospital. She is also an ALSO instructor and fellow of Minimal Access Surgery, organizing committee member for Safe Motherhood National International Conference 2017 to 24, and PG revision course, and OBG drills and gynae skills and drills from 2017 to 24. Next member, Dr. Ponnuru Malathi ma'am. I welcome her. And she is a medical educated professor and HOD GMC, Yardabri, Bhuvanagiri, Telangana, and Joint Secretary of OGSH 2017 to 18, and coordinated ICOG MEDA 2017, ISOPAR Treasurer 2022. She's a master trainer, Telangana State for 12 programs, the Peripatam IUC CUD and academic activities. And she's got many awards, Best Poster Prize, Mastering 5 Senses versus Technology 2019. And also Foxy, first prize in Foxy poster slogans. And her area of interest are QOC in maternal health. Current post, she is a member of ART and Surrogacy Committee, Telangana. I welcome Dr. Subhashini Karnal, MBBS Stipend OG, and she's a consultant in obs and gynae, laparoscopic surgeon, assistant professor in Sri Muthukumaran Medical College. She's done her UG in Chengalpet Medical College, PG in CSI Rainy Hospital, Thandayarpet, Foxy member, life member of IMA, Tambaram Cogs, and Indian Menopause Society, faculty in regional and national conferences. Dr. Nishita, who is a final, I welcome her. She's a final year OB-GYN postgraduate student from Savita Medical College and Hospital. And she's done her undergraduation from Meenakshi Medical College Hospital and Research Institute, Kanchipuram. And she's presented papers and posters at various national conferences, won 3rd place for poster presentation on tuberculosis in pregnancy at a national conference. Welcome, Dr. Nishita. And Dr. Imaya, who is doing Master of Surgery in Obs and Gynae, Savita Institute of Medical Science and Research Institute. And she's done her Bachelor of Medicine in Karpaga Vinayagar Institute of Medical Sciences. And she has got 3 papers and 4 posters in national conferences. She has published articles and research papers. Welcome, Imaya. I welcome all the delegates. And this is a revision course for the PG students. It is very useful. And today's topic is fibroids. So let us get on with the meeting. Thank you. So you can.
Thank you, madam, for the wonderful introduction. So I welcome our PGs, our Savita Medical College PGs, to start the presentation.
Good evening, ma'am.
Yeah, good evening. Nishita and Imaya. So I would be asking relevant questions whenever I feel like and stopping. I will not be taking the entire presentation. Is that okay for you, both of you, Nishita, Imaya?
Yes, ma'am.
Okay.
Can I start, ma'am?
Yes.
Good evening. Mrs. X, 42-year-old, P2L2, residing in Porur, belonging to socioeconomic class 3, studied till 12th standard, homemaker by occupation. A patient came with a chief complaint of heavy menstrual bleeding during menstruation for the past 6 months. History of presenting illness. Patient was apparently normal 6 months back, following which she had complaints of heavy menstrual bleeding during 6 to 7 days for 25 to 30 days cycle, changing 5 to 6 pads per day, associated with clots and dysmenorrhea, not relieved with medication. History of easy fatigability present since 1 month. No history of breathlessness or palpitation. No history of intermenstrual bleeding or postcoital bleeding. No history of.
Yeah. See, in the first slide, you have mentioned only one complaint. If you can go back to the first slide.
Yes,
Yeah.
ma'am.
Complaint was only
Heavy menstrual bleeding.
6 months. When you come to the presenting illness, just project it. Second slide, next slide. You added one more complaint. What is that?
Dysmenorrhea.
Why you don't think it's important? It has to be covered there. Is it not a chief complaint?
Yes, ma'am.
So whatever you say in the complaints has to be elaborated here, right?
Okay, ma'am. Yes, ma'am.
Yeah. So you missed out on
Chief complaints.
this mentioning a pain during menstruation in the chief complaint.
Chief complaints.
Go.
No history of abdominal distension, no history of mass descending per vaginum, no history of foul-smelling discharge per vaginum, no history of dyspareunia, no history of constipation, tenesmus, no history of bleeding tendencies, no history of cold intolerance, weight gain, lethargy, no history of fever, loss of appetite, loss of weight, no history of difficulty in micturition, increased frequency, or urinary disturbances. Menstrual history, she attained menarche at 14 years of age. Previously, she had regular menstrual cycles, 3 to 4 days per 30-day cycle, changes 2 to 3 pads per day, not associated with the passage of clots or dysmenorrhea. Her LMP was on Jan 27th. Marital married since 15 years. Living with her husband at present, non-consanguineous marriage. Obstetric history, P2L2, both term normal delivery, vaginal delivery. Antepartum, intrapartum, and postpartum events were uneventful during both. No history of contraceptive intake. Puerperal sterilization done 12 years ago. Not a known case of diabetes, hypertension, tuberculosis, bronchial asthma, thyroid disorder, cardiovascular disease, epileptic disorders, bleeding disorders. No history of blood transfusion. Surgical history of puerperal sterilization done 12 years back. Treatment history of symptomatic treatment taken for similar complaints for past 4 months. No history of intake of tablets taken for 3 days on and off, probably could either be tranexamic acid or metalspas. No history of anticoagulants intake in the past. Family history, no history of similar complaints in the family. History of no history of breast cancer, ovarian malignancy, colorectal carcinoma, endometrial cancer in family. No history of bleeding disorders in the family. Personal history, mixed diet, normal bowel and bladder habits, adequate appetite, normal appetite and sleep, no substance abuse.
General examination. Patient is moderately built and
Stop here, pause here. So till now you finished the entire history, right?
Yes, ma'am.
yes, ma'am.
Isn't it? So
Yes, ma'am.
based on the history, you have not done a clinical examination. Based on the history, what do you think the cause for the heavy menstrual bleeding? Based on the history.
Ma'am, it could either be adenomyosis
Mhm.
or leiomyoma.
And she also has breathlessness, so AUB induced anemia.
Okay. Anything else based on the history? Only two. You have said adenomyosis. You have said leiomyoma. Anything else?
It could either be endometriosis, it could be PID.
Yeah, chronic PID, pelvic endometriosis, right? Anything else? All benign conditions. You mentioned few benign, mentioned few, one condition related to infections. Anything else?
Malignancy.
Yeah, why not malignancy? So all this should be kept in mind. So right from the first slide, I would like to ask few questions. If we go, we'll finish off the history. So right from the first slide, go to the first slide. Can you go to the first slide? Yeah.
The chief companies.
Yeah. Okay. So can you define this heavy menstrual bleeding?
Yeah, having more than 8 cycles, according to cycles, if she's having more than 8 cycles per year, or she's having a bleeding for more than
If it's more than 80 ml, ma'am, if the bleeding per cycle is more than 80 ml, or if the duration of the cycle is also more than 8 days,
Okay.
then we can call it heavy menstrual
What-
bleeding, ma'am.
See, what are the main components to call as a heavy menstrual bleeding? What are the main components you have defined? One is duration, one you said
frequency
volume, and then
and frequency.
And also if any passage of clots, ma'am.
okay. What does the NICE define heavy menstrual bleeding as? Can one of you define heavy menstrual bleeding as per the NICE guideline? Because it covers one important aspect of heavy menstrual bleeding. Yeah. What
Maybe
is yeah.
when the heavy menstrual
Soakage
bleeding
of pads, ma'am.
interferes with her
NICE guideline?
quality of,
NICE
Quality of
guideline.
life.
interferes with quality of life.
Exactly. So it says very specifically, which interferes with the physical, social, emotional, and the mental quality of life, irrespective of the frequency, regularity, and duration. So just a heavy flow interfering with any of this quality of life is heavy menstrual bleeding. So you need to know various definitions. Okay.
Okay, ma'am.
Because it covers one important aspect, that is quality of life. Okay.
Yes, ma'am.
And another important point you mentioned here is the past 6 months. So what do you understand from this? What do you understand from this history that it is for the past 6 months she's suffering with the heavy menstrual bleed? So it indicates what? It indicates chronic, isn't it? That's the significance of this duration. It is not an acute AUB, you're dealing with chronic AUB. Okay? Am I audible?
Yes, ma'am.
So in every complaint, you'll have to understand the significance. The screen is lost.
Yes.
Yeah.
Screen is gone. Yes, ma'am. I think the candidate has.
Can you project it again?
The two. Sahiti. 1 second, ma'am. I'll get in touch with her.
Both of them are lost, I think.
Yes, they are using one computer actually. I'll just contact Sahiti. Hello, Sahiti. The screen is lost. The screen is gone. அவங்க present பண்றாங்கல்ல, that screen is lost. இல்ல அவங்களும் இல்ல. டிஸ்கனெக்ட் ஆயிருக்கு. You please ask them to reconnect. Okay, thank you.
They didn't like my questions.
I think connectivity is lost, ma'am. Sorry. We have just, she's there.
Ma'am, the connectivity was lost, ma'am. Sorry, ma'am.
That's okay.
Yes,
Come on, rejoin.
Okay.
yes, ma'am. Yes, ma'am.
Hello, ma'am.
இமையா 2 சிஸ்டம்ல ஜாயின் பண்ணுங்கம்மா.
Yes, ma'am.
ஒருவேளை கனெக்ஷன் போனாலும் இன்னொன்னு இருப்பீங்க. ஓகே.
Okay, ma'am.
Screen sharing. Share பண்ணி. எப்படி பண்றது?
Very interesting topic, AUB.
Yes.
And very common. And definitely they'll get these cases.
Absolutely, and practical also, ma'am. Every day, this is the most common these days.
Correct.
And most, everyone treats it in a different way. It's best we follow the AUB guidelines.
Correct.
Everyone just puts them on hormones and they forget the infection, the other parts, most of the.
Ishita, can you come?
Yeah, they don't think malignancy should be considered as one of the differentials.
Yes, ma'am. And another major thing they do is they don't do a speculum in many places. Probably they don't have the proper setting, or because we are in ESI, we see many patients seen by other clinicians, but they fail to see this do a speculum. And after coming here, as you said, we see a lot of cervical malignancies.
Actually, in our institute, we missed out one choriocarcinoma. It was thought to be a neomyoma. So
Okay,
they
ma'am.
tested her for abdominal hysterectomy. Lot of friable, everything. The clamps were just coming out.
Oh dear.
Then on the table, they have done a urine pregnancy test. It came positive, and post-op the HCG was in laps. So never,
Yeah.
never forget malignancies.
Malignancy, absolutely. We first think so. I took some 10, 15 speculums from my house, and I just gave it because it's every day, anybody walks in, speculum is a must. That is what we have kept as a guideline for our OPD.
Exactly. Ruling of cancer is very important. And that is the major question the woman and the family have.
Absolutely.
Is
That
it
is why
if I don't get operated, will it
Yes.
progress cancer or am I having cancer? That's the
cancer.
they ask. That is the major concern.
Absolutely. And one thing, ma'am, last week we had huge impacted fibroid. We had to do an emergency laparotomy, impacted in the vagina, ma'am. Huge one. Polyp has grown so much, and she had constipation, necrosis, ischemic necrosis. Whole ward was smelling because of the impacted fibroid polyp. Thank God it came back benign yesterday, but we had to do midline laparotomy. Huge one, very huge.
Oh.
Yes, ma'am. Anyway, we'll continue. Thank you so much, ma'am.
Yeah. No. You go to the history itself. See, any other slide you have? Yeah. Yeah, this is over. We just discussed about the definition and we have discussed about the NICE definition, which includes the quality of life and the importance of 6 months to call it as a chronic AUB. And coming to this, can you define what are the normal length of the cycle, duration, all that here?
Normally, it bleeds for 7 to 8 days, ma'am.
3 to 8 days can be normal, ma'am.
The lower number?
3, ma'am.
So always tell in a range 2 to 7 days. Okay, fine. Then?
Yes, ma'am.
Okay. How do you want?
And the volume of bleeding is 30 to 80 ml, ma'am.
20 to 80 ml. And how much of iron is lost? Here in your case, she has a bleeding for the past 6 months. So if the woman normally loses 20 to 80 ml is considered as something normal, how much of iron is lost in one menstrual cycle? Assuming it is between 20 to 80 ml, the normal loss, how much of iron is lost per month? Nishita?
Yes, ma'am.
Imaya?
Yes, ma'am.
So it is, if the blood loss is around 20 ml, she'll be just losing 10 milligram of iron per month. And if it is 80, it is 3 times. That is 30 to 40 milligrams of iron. So in your case, you imagine for the past 6 months. So definitely she'll be having all symptoms of anemia. So you'll have to know this. So 10 to 30 to 40 milligram of iron is lost by every woman in normal flow per month. Okay.
Okay, ma'am.
And coming to this dysmenorrhea,
Yes, ma'am.
what would be the better one here? What would be the better terminology here in this sentence? Are you allowed to write dysmenorrhea in the present illness? It's in the patient own word.
Pain during menstruation, ma'am.
So pain during menstruation. So that would be, in a medical term, you call it as what? In your case, add something to this dysmenorrhea.
In spasmodic.
Okay, that's a type of dysmenorrhea. So it's a case of secondary dysmenorrhea,
Yes, ma'am.
isn't it?
Yes, ma'am.
Yeah. Tell me some of the causes for this secondary dysmenorrhea. See, history taking should be so detailed and we'll have to come to a provisional diagnosis based on the history, then with the clinical examination.
Yes, ma'am.
So-
The secondary causes are again leiomyoma, ma'am, adenomyosis, any pelvic pathologies, ma'am, like again endometriosis and pelvic inflammatory disease.
Chronic PID.
Yes, ma'am.
It is the same causes. Okay. So
Yes, ma'am.
secondary dysmenorrhea. Okay. And another important thing, not relieved with medication. You mentioned this, not relieved with medication. So how do you interpret this? When the woman is saying that she's not relieved with medication, how do you interpret this? As a clinician, what do you understand by this?
This is not a case of primary dysmenorrhea, ma'am.
See, I don't know whether this medication was given only for the pain or for the bleeding or for both.
Okay.
There's no description whether never relieved, which is not relieved, the bleeding or the pain or both. This is very,
Dysmenorrhea.
I don't know. You'll have to tell me.
Dysmenorrhea.
So what do you understand? Not relieved with medication.
Maybe she had medication only to reduce the bleeding.
No, you cannot say maybe because you have taken the history, right? Esther, right?
She was taking tablets on and off, ma'am, but no documentation of that. Might be traumatic or.
Suppose she has taken the medication as per, and she was very compliant and she has taken the medication, but still she is not getting relieved with medication. How do you interpret this history?
We have to write in detail, ma'am, either pain or bleeding, which was relieved medication.
Of this finding. That means there is an underlying pathology. That means the heavy menstrual bleeding and the pain during menses is because of some pathological condition.
Yes, ma'am.
That is the inference of this. And second important inference, one is it's a pathology. There is some underlying pathology. Second interpretation of this sentence in the history. What does NICE guidelines say about evaluation of endometrial cancer? when to consider or rule out endometrial cancer. It has mentioned few important factors like
When endometrial aspiration or ECC.
in considering ruling out endometrial cancer, in considering endometrial pathology, it has given very nice points. What are they? What are the risk factors you'll have to consider to rule out endometrial cancer? Maybe I'm not framing the question correctly. You're not able to understand. Age. Okay, I'll give you some clues. Depending on the age. Yeah.
Age, ma'am, in the reproductive age group, like 40 years and beyond, and obesity, diabetes.
Exactly. Yes, diabetes, hypertension, diabetes. Anything else? Family obesity.
Family history.
Anything else? Not getting relieved with medication. This line is a very catchy line in your history taking. So not getting relieved with medication always indicates that you will have to rule out endometrial cancer. That's the importance. Got it? Importance
Yes,
of...
ma'am.
Yeah. See, at the end, you'll have to summarize, ma. Either of you, please make a note of the question and the answer, because at the end, you'll have to give the key messages. You will have to give, not me. Okay?
Okay, okay.
Now you said history of easy fatigability present since 1 month. Breathlessness, palpitation. Okay. All this points to what?
Anemia.
Yeah, chronic anemia. This is the quality of life, isn't it? So this is what the NICE says. You should consider the QOL as in the definition of heavy menstrual bleeding. Okay.
Yes, ma'am.
Okay, move on to the next slide. Now, imagine that instead of a no, there is a positive history in your case. There is a history of abdominal distension. How do you interpret this finding? So make everything as yes, and please tell me.
If it is a history of abdominal mass, like it can be either fibroid, adenomyosis, palpable fibroid, palpable adenomyosis, or can be other causes like ovarian mass with ascites. The history of if she's having prolapse, mass descending for vagina also, she may have
What's
bleeding with
commonest first DD in the reproductive age group?
Leiomyoma.
Reproductive age group.
Reproductive age group. Who is
Reproduction. Someone say.
pregnancy.
Okay, pregnancy, ma'am.
so why do you don't think of pregnancy? That is the first
Full
thing.
bladder.
Yeah. Then,
Full bladder.
so how do you differentiate?
Any tube.
Okay.
We have to ask the patient to.
How would be the history? How would be your clinical findings if it's a full bladder?
There'll be suprapubic tenderness, ma'am.
History.
On examination.
History.
She's coming.
She will have the urge to pass urine, but she can't void.
She come with retention of urine, ma'am. I'll give you a history of retention of urine and discomfort and pain in the lower abdomen. So on clinical examination,
There will be
tenderness. Suprapubic will be there, ma'am.
okay, there'll be discomfort, tenderness on palpation, and then
we can ask the patient to void and come after the scan.
palpation findings.
Consistency, border.
Boggy,
Cystic, no?
Yes, ma'am. Cystic and
uniform, cystic, uniformly distended, smooth.
Defined? Poorly defined. Margins.
poorly defined margins.
Defined. And how do you confirm that it's full bladder? One is history, retention of urine. Then how it
Examination. Then we'll have to After she empties her bladder, we'll have to examine, ma'am.
She can't, she has come with retention of urine. You will have to pass a catheter,
Catheter.
then it disappears, right? She has come with retention. How can she pass? So by catheterizing, you will empty the bladder and then the mass disappears. So you should be knowing it's an undergraduate level question. How do you differentiate and full bladder pregnancy? So pregnancy,
We can feel the fetal movements.
first is history, ma. History.
Ma'am, we have to ask her about the
No,
signs
no.
and symptoms of pregnancy,
No,
ma'am.
first history. Amenorrhea.
Amenorrhea.
Yeah, right then. Yeah, as you said, signs and symptoms. Okay, then.
Yes, ma'am. Signs and symptoms of pregnancy. Then if she's having any perception of the fetal movements,
Mm.
and
Okay.
then on palpation, if we are able to feel the fetal parts and all, ma'am.
Allotment.
The allotment, yes, ma'am.
Yes, then.
The other DDs, ma'am.
Little heart and your Doppler.
Yes, ma'am.
It will confirm actually, isn't it?
Yes, ma'am.
So see, examiners can stop you anywhere and ask you anything. So you'll have to be prepared. Say, suppose she has a mass descending per vaginum. Make it everything yes, 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 and answer quickly.
Yes, ma'am.
History of mass ascending progenon can be either prolapse or fibroid polyps or endometrial mucosal polyp.
If it's a fibroid polyp, as madam was just mentioning, how would be the history?
There'll be intermenstrual bleeding, ma'am.
Okay. Anything else?
Mostly it will not be associated. It will not be associated with dysmenorrhea.
Blood stain discharge, ma. Madam was saying no, there are a lot of necrosis
Yes, ma'am.
there. So there'll be foul smelling, profuse vaginal blood
Vaginal discharge.
discharge. It becomes a DD for cancer cervix, right?
Yes, ma'am.
Okay. Anything else? Mass descending per vaginum. One is you said is prolapse, genital.
Mucosal polyp.
Inversion of uterus.
Yeah, chronic inversion of the uterus. You know how to differentiate, right? What is the differentiating point between both?
Uterine sound test, ma'am. If
So,
we'll be able to pass the uterine sound in a case of fibroid polyp, whereas in the chronic inversion of the uterus, we'll not be able to pass the sound at all, ma'am.
anything else?
How do you identify the uterus, ma, first?
Cervix can visualize a cervix in case of prolapse or polyp, ma'am. But in case of acute inversion of uterus, we can't see the cervix.
No, it is a huge polyp. You can't even see the cervix. It's fully filling the vagina. Any other finding? Per abdomen finding.
If it is palpable, Masna, we can feel the fibroid per
What about the
abdomen.
fundus?
Per abdomen, something is missing now in chronic.
Yes.
Fundus, what is
Fundus will
It
not,
could not
be
be
palpable,
palpated.
ma'am. Per abdomen in the chronic inversion of uterus.
That is one important finding. Now go to this. History of foul smelling discharge. Just now we have said. Yeah, come on, tell me.
If history of foul smelling discharge per vaginum is present, then it signifies any infection or degeneration.
Or also the fibroid polyp, as it was before.
Why not?
Infection and degeneration of fibroid or any infections.
Why not cancer cervix?
Yes, ma'am.
Isn't it? Don't forget. Anything else can give this foul smelling discharge per vaginum?
Infection, necrosed fibroid with necrosis or degenerations.
Yeah, anything else, ma? Forgotten pessary of foreign body. Very important, isn't it?
Yes, ma'am.
So remember for every case, you remember like this, there are benign, then infective, third is malignancy. 3 groups. Try to put at least one condition for each group. You will be right. Benign, infective, malignant. Okay?
Yes, ma'am.
When do you think dyspareunia plus? Which type of dyspareunia you're more concerned with?
superficial or deep?
Some deep dyspareunia, ma'am.
So tell
It
me.
will be associated with endometriosis or an adenomyosis also. It will be associated with dyspareunia. ma'am.
Okay. How about in chronic PID?
Yes.
It will be
Also, that
associated.
also is associated with dyspareunia.
Okay. Then, madam was just telling no constipation.
If fibroid pressure symptoms,
If
can
it is a
manifest.
posterior wall fibroid, then there'll be a difficulty in
No, it is
defecation.
impacted. Madam has given a very nice point. Regularly, we see so many fibroids posterior wall, but they don't come with constipation. If
What is the other
impacted,
symptom with which they come? Posterior wall fibroid.
any other complaint?
Usually they will come in the midnight saying one prominent complaint.
Retention of urine.
Yeah.
Retention of urine.
Right.
Yeah.
Next thing, bleeding tendencies.
Any coagulopathy.
At this age, what type of coagulopathy you suspect? She's 42 years. Coagulopathy is suspected in what age group?
In childhood, ma'am.
Right?
Adolescent age group, right?
From the time of menarche, the history will be like that, right?
Yes, ma'am.
What is that criteria where you will have to go with the coagulation test? There are some criteria, major and two minor criteria, which will say that you will have to rule out coagulopathy. Tell me that criteria. How do you suspect coagulopathy in an adolescent girl?
If she's having heavy menstrual during menses, if she's having heavy menstrual bleeding or bleeding from other sites.
No, major, minor. So the history would be like heavy menstrual
bleeding.
menarche. That is the typical history. Right from menarche, they have heavy menstrual bleeding. And what are the major criteria to say that it could be postpartum hemorrhage, tooth extraction, or any kind of surgery, they have a bleeding, then you will have to go with any one of them. Then you will have to go with the coagulation profile.
Yes.
Minor, as you said, you were mentioning, no?
Bleeding from any
other sites.
Other sides.
Bleeding gums.
While brushing the teeth, bleeding gums.
Bleeding.
Like ecchymosis.
Ecchymosis. These are all minor. Epistaxis. Okay.
Yes.
All these are the minor, and at least two of them should be there, and 2 episodes at least in a month, like that, something like that. Okay.
Yes, ma'am.
So you'll have to know. That means you'll see, you don't restrict your reading to only fibroid. You will have to read even AUB. Okay. Right. And this history, if it is positive, cold
Cold
intolerance.
intolerance, weight gain, or lethargy is positive. That means we have to suspect thyroid
Hypothyroidism.
disorder, ma'am. Hypothyroidism.
Okay.
This could also be a cause of AUB.
Okay.
Fever, loss of appetite, and loss of weight is present, then we'll have to suspect malignancy.
Okay. Now you're telling malignancy first, right? Always first in benign infection, malignancy. In infection,
Which one
Can be PID, ma'am.
infection, tuberculosis, ma.
Tuberculosis. Yes.
HIV, isn't it?
Yes.
Tuberculosis. So keep like that, benign infection and malignancy.
Malignant.
Right. This we have already discussed. Madam said it's a posterior wall fibroid. And when do you have this increased frequency?
In anterior wall
Anterior
fibroids,
Cervical fibroid.
anything which give pressure
Broad
on
ligament fibroid.
bladder.
Yeah, irritates the bladder. Any other urinary disturbance? What is the any other urinary disturbance?
Urinary retention can happen if it compresses the ureter, like broad ligament fibroid, lateral wall cervical fibroid, and all.
What do?
It will compress the ureter.
So what will happen?
Hydronephrosis.
Hydroureter, hydronephrosis. So if it is, have you ever seen that change in any of the cases till now?
Yes,
Hydro-
ma'am.
Okay, good. Then what did you counsel them? If you have seen a ureter hydronephrosis, it was a big cervical fibroid or a broad ligament fibroid or huge fibroid sitting on the pelvic brim. All this can cause these pressure symptoms. So how do you counsel? She'll be worried, right?
Yes, ma'am.
So how do you counsel?
We can suggest IVP, ma'am.
No, why? It's already there, no? Ultrasound has said ureter
You can keep
counseling.
by
Counseling. So you should tell this is a
To
reversal.
tell this.
It will
Okay.
just disappear once you do a definitive surgical treatment, not to worry about that. And one follow-up scan is definitely required to see the reversal. Any other significance of this ureter hydronephrosis pressure symptom? Hematological significance of this change? You said you have seen, no?
What will be the associated, any other, usually you expect anemia, right? What will happen?
erythropoiesis.
Hydroureter, more so hydronephrosis because of the pressure. What can it do? Something opposite to anemia.
It causes
Polycythemia, ma'am.
erythrocytosis. Lymphomatosis, erythrocytosis.
Is it polycythemia, right?
Polycythemia.
Polycythemia.
Poiesis and polycythemia. So how do you counsel when you see such a picture?
This we can also reassure her that this is also reversible, ma'am.
And
After the surgery.
what is your worry? Unlike in hydroureter hydronephrosis, what is your worry when you see polycythemia?
We'll suspect malignancy.
No, not malignancy.
Polycythemia, what is the complication you anticipate?
Thrombosis.
So there is risk of thrombosis. So you'll have to operate as early as possible. Otherwise, thrombosis can happen. Unlike your there are benign changes, pressure. It's only the pressure changes, but polycythemia is little dangerous. Okay? Let's move on.
Menstrual history.
Yes.
She attained menarche.
Hmm.
I should read, ma'am. Menstrual history. Attained menarche at 14 years of age. Previously, she had regular cycles. After like 3 to 4 days per 30-day cycle, changes to 3 pads per day, not associated with passage of clots or dysmenorrhea, ma'am. LP was on January of 27th, 2024, ma'am.
Different menstrual changes she has developed in the past 3 months, 6 months. Instead of 3 to 4, now the flow is lasting for?
She 7 to 8 days.
ma'am.
Okay, 7 days. Earlier, how many pads she was changing per day?
2, 3 to before 6 months, 3 to 4 pads, ma'am.
So it's not like that, See, you tell me normally how is the blood flow, loss of menstrual blood? Normally, physiologically, again you're lost. Nishita?
Jan's
Ma'am,
27.
Yeah, say suppose previously she had a cycle lasting 3 to 4 days, right? So normally how the menstrual blood loss happens, which day it is maximum? Tell me like that.
Second day, ma'am.
How much is the approximately second day? How much approximately in the third day? In percentage. Yeah, in percentage.
Ma'am, almost 60 to 70% in the second day there'll be
Okay. Third day?
it is decreased, ma'am. It is 10 to 20, like 20 to 30% like that, ma'am.
On day 3. So second day it is somewhere or as you said 70 to 80%, but on the third day it is 90%. Fourth day it okay. Now this cannot be generalized. Every day she used 2 to 3 pads is not correct. So it is the maximum flow happens on the third day. So that may be, so you'll have to say the number of pads she's using in heavy menstrual bleeding. What is the, how do they give the history? In the normal menstrual cycle, I said the maximum flow is on day 3, day 2 and day 3. It tapers on day 4.
Whereas
Or-
in heavy menstrual bleeding, they'll be using maximum number of pads throughout, ma'am. It
Ah,
doesn't follow this cycle.
that is the difference. Okay,
Yes, ma'am.
got it?
Yes, ma'am.
Okay, and this is secondary dysmenorrhea. Type of dysmenorrhea,
Spasmodic.
This is
when do you get
congestive, ma'am. Secondary dysmenorrhea, ma'am. Associated with the pelvic pathology.
okay, congestive. Okay,
Yes, ma'am. Congestive.
right. So you mentioned living with the husband at present. One more history is very important in any gynecological case. What do you think it is?
Whether she is sexually active.
Okay, sexually active. Sexual history, isn't it?
Yes, ma'am.
For that, is it not affecting the quality of life here? That is very prolonged, right? There is fatigability. She has all the symptoms, right? Easy fatigability, no?
Yes,
So,
Yes, ma'am.
sexual history,
Ma'am.
where is the sexual history?
We should have mentioned it, ma'am.
That you'll have to mention in every gynecological case.
Okay,
Okay.
ma'am.
Go ahead, continue.
Obstetric history, para to live to both term normal vaginal delivery, antepartum, intrapartum, and postpartum events were uneventful in both pregnancies. Last childbirth was 12 years ago.
Okay, now tell me the importance of this para to live to in your case, because you know that you're presenting a case on fibroid. So what is the significance of this? Live
Ma'am,
to.
low parity or more have a more increased risk for leiomyoma, ma'am. Whereas high parity, they are more in favor of adenomyosis and pelvic organ prolapse.
Okay. Fine. And how about this contraceptive pill intake? What is its relevance here in this case?
Contraceptive pill intake, ma'am, it is relevant because of the degenerations, ma'am, in case if in leiomyoma. And also it is more, it reduces the chance of leiomyoma, ma'am.
Which contraceptive?
OCPs, ma'am. Like
combined.
Combined.
Combined pill and then
combined.
Progesterone only pills also reduces it.
and DMPA,
DMP.
injectable. So
Injectables.
these are two contraceptives. See, always most of the cases in our country, it is always no history only. There is never a case where there is a history of contraceptive pills taken. There is hardly anybody, but this is one thing we'll have to concentrate. What are the other benefits apart from reducing the incidence of leiomyoma? Other benefits?
Ma'am,
The OC pills can
for,
also endometriosis. Also.
as a contraception, it can be used, ma'am.
No. What are
Contraceptive uses.
contraceptive benefits? Because we'll have to promote contraceptive pills. So we'll have to talk more on the non-contraceptive benefits. One of them is incidence of fibroid decline. Okay.
Ovarian cancer also.
Produces anovulation, right? So,
Yes, ma'am.
what are the malignancy?
Ovarian
Anything?
cancer.
Anything connected with pregnancy?
Non-contraceptive benefits.
Ovarian cancer, it reduces incidence.
It's a commonly asked question, right? Right from pelvic inflammatory disease, ectopic pregnancy, anemia, heavy menstrual bleeding, pain, during menses,
And what are this?
endometrial cancers, ovarian malignancies, leiomyoma. So many benefits are there. So we'll have to start talking on this and see that we should not be mentioned. I mean, increase the contraceptive usage actually. Okay. Go to the past history.
She's not a known case of diabetes mellitus, hypertension, tuberculosis, bronchial asthma, thyroid disorder, cardiovascular disorder, epilepsy, or bleeding disorders, ma'am. No history of blood transfusion.
Okay. Say, suppose she was having a history of diabetes and hypertension, were positive in your case. So, what do you think? So, heavy menstrual bleeding, she's a diabetic, she's a hypertensive.
Respected what?
We can like it is more in favor of endometrial carcinoma.
So, think of that. Right. Okay, move on to the next slide.
Treatment history. History of symptomatic treatment taken for similar complaints 4 months back. History of intake of tablets taken on and off for 3 days. Probably could either be tranexamic acid or meftalspaz. No history of anticoagulant intake in the past.
We'll just stop here. So, if you were the consultant, imagine that you are the consultant. How would you give this tranexamic acid and meftal? And what is its mechanism of action in controlling the pain and heavy menstrual bleeding?
Tranexamic acid is antifibrinolytic, ma'am.
Okay.
If she is having heavy menstrual bleeding, we will give like 1.5 milligram TDS.
Milligram?
Gram.
1.5 gram TDS for 5 days.
Tablet,
3
thrice.
to 5 days.
So, how many strengths it is available? How many, what are the combinations and all it is available?
It's
5
available as a 500 mg.
500 and also 650.
1 gram. 650.
650 also is available. Okay. So, how do you give the prescription?
Tablet tranexamic acid 500 mg thrice
3 tablets.
3 tablets
3 times.
3 times, ma'am.
Before food, after food, what
After
food.
is
food
the side effect?
for 5 to 7.
And don't you tell her to start only during menses and restrict it only the first 5 days? See, your prescription should be like
Yes, ma'am.
start, when to end, how many days, what is the dosage, when to take, and warning on the side effects, if any. That should be your prescription, right, as a consultant? So you start on, ask her to start on
Day 1 of
one of the cycles. For how many days?
To 5 days, ma'am.
Yeah, 5 days. Any contraindications?
Contraindications.
What is the contraindication?
any thromboembolism history.
Okay. Any precautions to be taken when you're giving this prescription of tranexamic acid? Commonly used drug now. So co-prescription, to avoid a co-prescription with?
What does it cost?
You said no, you don't give when there is a thromboembolism. So you avoid a co-prescription, commonly given drug for control of bleeding.
Ocipils.
Along with anticoagulants.
Yeah, estrogen containing pills. So you don't give, you don't combine COC with the tranexamic acid. After 5 days, you can start, but not together. Because you said, rightly said, there is a risk of thromboembolism, right? And how do you give this? Tell about this meftal, mefenamic acid.
And it is a NSAID, ma'am. That can be
Mechanism.
it can be given.
What is the mechanism of action, Pa?
Ma'am, it inhibits the prostaglandin
So
COX-2 inhibitor. Okay. So
ultimately, how does it reduce the bleeding? Prostaglandins, dilation, constriction. What is
This
there are two types, right? Vasoconstrictor, vasodilators, prostacyclic,
the
thrombo.
spas, right? Neptal spas. So
It's a vasodilator, ma'am.
dead.
Dilate it, then bleeding increase, no?
Sorry, ma'am, vasoconstrictor, sorry.
Think and answer, ma. Your aim is to reduce the bleeding, so you're trying to constrict, right?
Yes, ma'am.
So
Normally, what happens during menstrual cycle? How does the bleeding gets controlled?
how we are stopping, how we are that bleeding getting stopped on day 3, day 4.
progesterone drop.
Stop.
The bleeding is from the vessels. So what should happen?
Constrictions, like myometrial contractions,
Platelet plug,
like living.
thromboxane.
There are a lot of steps how the bleeding is being controlled, right? Starting from epithelial growth, then platelet production. Each and every day the mechanism is, you need to know about that.
Okay. So how are you going to give this? A combination separately you can give, isn't it?
Yes, ma'am.
Only during the menses. Start from the day
Day
one,
one of
only to 5 days. And what's the precaution? There we said thromboembolism. Here, what is the thing you look into? What's the problem with
NSAIDs.
Intensives. Liver function test.
sorry? What happens if she has a gastric ulcer? What happens to the renal function? What happens to the renal blood flow?
It reduces the renal blood.
Yeah, so at least one creatinine level you should be having. Be monitoring, because this prescription, once you give, they'll go on, they keep on taking, no?
We have seen so many patients coming with abnormal RFT, because of the misuse of this Meftal. We have seen patients. So you need to counsel the patient.
It cannot be just, they can't continue to take like that. And any other effect the NSAIDs have on the platelet or no? It's platelet friendly or not friendly? NSAIDs, ibuprofen, naproxen, all that. Friendly or not friendly? So it reduces the platelet function. NSAID should not be given when there is a thrombocytopenia. It should not be given peptic ulcer. It should not be given when the renal functions are not right or a raise in creatinine. So drugs you'll have to thoroughly know. Okay.
Okay, ma'am. Okay.
So anticoagulants in the past, suppose that she is on anticoagulants and that is the cause of the heavy menstrual bleeding. In the palm coin, where do you fit that case? Where do you fit the case in the palm coin if the bleeding is secondary to her usage of anticoagulant?
Be prescribed, no?
No, ma'am, it is
So if it is medicine induced?
Other causes.
Yeah,
Hydrogen.
it doesn't come under coagulopathy, it comes under iatrogenic, you're right. Right. Now go to the family history.
Family history, no history of similar complaints in the family. No history of CA, breast, ovarian malignancy, colorectal carcinoma, endometrial CA. No history of bleeding disorders in the family.
Family. So what is more important? Which family members you mean to say?
We have to ask about the mother.
Maternal.
No, my mother and the siblings, ma'am.
So it is always first degree.
Yeah.
First degree relatives.
First degree for cancers, everything is the first degree. What do you understand by first degree relatives?
Siblings.
You just
Blood
told,
Siblings.
What you told is the same.
What siblings?
you just told me, no?
Siblings.
The mother and the
Mother, siblings, and daughter. She also becomes first degree. Daughter also or first degree. Okay?
okay.
Okay. So, no blood. All this is fine. See, do you think she has easy fatigability and she's able to have adequate sleep? Is the
On
complaints?
exertion. On exertion only she had discomfort. Ma'am.
Okay, otherwise her sleep is undisturbed. Okay. Okay. And about the malignancies, tell something about the malignancy. History of breast, ovarian, in detail you have asked for every cancer, no? You tell me the importance. What are the different syndromes you know of?
If the BRCA gene positive, she will be family history of BRCA gene positive can have breast cancer with ovarian
Breast and ovarian
cancer,
malignancy,
malignancy.
ma'am.
BRCA1 and BRCA2 are different, no?
Yes, ma'am.
So what do you understand by BRCA1? And what do you understand by BRCA2?
In BRCA1, more chances of breast cancer, ma'am. Whereas in BRCA2, there's more chances of ovarian malignancy, ma'am.
Cervical malignancy.
BRCA1 is ovarian. 50% chances of ovarian. So it is what type of BRCA1 is deficient? What does it mean to you? DNA repair. BRCA2 is tumor suppressor gene. You should know the gene on which chromosome also. Which chromosome represent BRCA1? Which chromosome represents BRCA2? It is represented on which chromosome? A little of
Chromosome 8 and chromosome 11, ma'am.
BRCA1 is chromosome
8.
17. BRCA2 is chromosome 13.
13, sorry.
Okay. So any other apart from BRCA1, BRCA2?
HNPCC.
Lynch syndrome, HNPCC,
Lynch syndrome.
colon, endometrial, ovarian. Any other? You're right. BRCA1, BRCA2, Lynch syndrome, HNPCC. Any other? Associated with endometrial, breast, and thyroid cancer.
Men's
Yeah.
syndrome.
Cowden syndrome disease.
P10. Yes, ma'am.
P53 mutation. So these are the three things which we'll have to know, because breast and endometrial thyroid is seen in Cowden, HNPCC, colon, endometrial, ovarian. As you rightly said, BRCA is breast ovary. Okay?
Yes, ma'am.
So because you have to take detailed history, I thought I'll ask you. Go to the next. Go to the next slide.
General examination. Patient is moderately built and nourished. Height is 158 centimeters. Weight 78 kgs. BMI 31 kg per meter square. Pallor is present. No icterus, cyanosis, clubbing, pedal edema, generalized lymphadenopathy.
BMI or something else you can write here, right? Apart from something else you could have mentioned. WHO class.
Class of
Obesity. So it belongs to
Just 3.
1 or 2. There are only 3 classes, 1, 2, 3. So class 2
Class 2, ma'am.
was cross 30. So in your case, is there any risk of endometrial cancer, any positive features?
Obesity.
Yes, so
She does not have any comorbidities, ma'am.
yes.
So
One
it's
worry I have is she is not responding to your medication. That I told you in the beginning itself, no, that is also considered as one of the factors. Non-response to the medication is an indication for evaluation for endometrial cancer. That is another one. There are only 2, I feel. Okay.
yes, ma'am. No icterus, cyanosis, clumping, pededema, generalized lymphadenopathy, breast, thyroid, and spine clinically appear to be normal.
Okay.
Vitals, temperature 98.4, BP 100/70 mmHg, pulse rate 96 per minute, regular in rhythm and volume, respiratory rate is 18 per minute. Systemic examination, CVS S1 S2 heard, no murmurs, RS normal vesicular breath sounds heard, no added sounds, CNS no functional neurological deficit.
Okay.
For abdominal examination, inspection, obese abdomen, umbilicus normal position, all quadrants move equally with respiration, a subumbilical scar of about 2 centimeters noted and was healthy, probably puerperial sterilization scar, no dilated veins, sinuses, visible pulsations, hernial orifices were free.
Okay. It is obese abdominal wall, but is it laxity is there or not? Is it
Laxity
she
was
had
there.
vaginal births?
Yes, ma'am, laxity was there, ma'am.
Okay. Go. Continue.
Palpation, midline mass arising from pelvis corresponding to 18 weeks
How
size.
make a statement like this arising from the pelvis that just by palpating the midline mass? How do you know it's arising from the pelvis?
If the lower border,
But you have not gone to that point, no?
yes, ma'am.
You cannot make a comment like that unless you finish the complete examination.
Okay, ma'am.
Okay?
Okay, ma'am.
Yeah.
Irregularly enlarged, firm in consistency, non-tender, well-defined margins, lower border could not be made out, side-to-side mobility present, no other organomegaly.
Do you think this is enough midline mass? You said so many quadrants are there in the abdomen. You have not mentioned which quadrant it is and what is its importance, significance. Description of the mass as per the quadrants of the abdomen. Why should we describe it that way? What is its importance?
We will know the origin, ma'am.
We can look for any organomegaly.
No, I'm asking about this mass. You just said it is arising, it is 18 weeks, but you never said which quadrants it is occupying. You have described as per the quadrants. That is missing here.
Okay, ma'am.
And what is its importance? Why I want to know?
Adnexal mass,
Extent of the
All those regions, no? Iliac fossa, everything I need to know.
yes, ma'am.
Why?
need to know the extent of the size of the extent of the
Extent. Okay. And then?
The origin. So if it is in the hypogastric, the organ will be different. Like if it is confined to one side, then so it's like that, right?
Yes, ma'am.
That is one. And as a surgeon, why do you want to know the mapping of this? Quadrant-wise mapping and
To plan our incision.
plan our incision is okay. And then?
Also the type of surgery, ma'am.
Yes. How do you decide that?
Either laparotomy or laparoscopy.
Is it laparotomy or laparoscopy or vaginal?
Vaginal hysterectomy or yes, ma'am. Vaginal or abdominal approach.
How do you decide that? Say suppose the
If
mass
it is less size,
is only in the midline. That means it is in the hypogastric, umbilical, and going like that upwards. But the mass is also occupying the iliac fossa. What is the interpretation? Got the point? Hypogastric, umbilical region, vertically growing. Another mass which is vertically growing and also growing sidewards. The width is more
we
occupying.
can't do laparoscopic. We can't go with laparoscopic approach. We have to open.
No. I'm talking.
No, if it is a broad.
What is the
tumor,
structure you're afraid?
Yeah. When you
Uri-
operate, laterally we were talking
ureter.
about.
We have to. Ureter. We have to have a caution on.
Any mass which is broad and occupying the iliac fossa, vaginal approach becomes very, very difficult. Broad masses cannot be vertically growing without a lateral extension can be managed from below because she had two vaginal births, right?
Yes.
Yeah. So if there is a good expertise, we can still go by the vaginal approach. So the width is important here, and there is no description of the mass quadrant wise here. So that is missing. Okay.
Okay, ma'am.
Okay. Okay. After palpation,
Yes, ma'am. Percussion, dull note over the mass noted. Flanks are resonant. No fluid thrill or shifting dullness.
okay. If I say there is a fluid,
Yes,
there is
ma'am.
an abdominal fluid. So what is your interpretation? There
It
is a
could be ovarian cancer.
there is a
Su-
fluid.
Pseudo-mix syndrome.
What is mix and what is pseudomix? When do you call this mix?
Pseudo-mix syndrome it will be associated with fibroid, pleural effusion, and ascites, ma'am.
Mix?
Um,
Ma'am, if it's fibroma or thecoma,
If it is associated with ovarian, it is mix. If it is associated with the leiomyoma, it becomes pseudomix. Okay?
okay, ma'am.
Okay. Auscultation. Okay.
Normal bowel sounds heard. No bruit heard over the mass.
Okay. So what is this? How do you interpret that no bruit on the mass?
No vascularity, ma'am. No shuffle heard.
Subcapsular vascularity is not there much. Okay.
Yeah.
Okay.
Pelvic examination. Inspection. External genitalia appears normal. First speculum examination. Vagina and cervix appears healthy. Bimanual pelvic examination. Uterus enlarged.
Apart from writing as healthy, any other finding is important because this is an 18-week size mass.
any discharge for vagina.
Okay. You said it's healthy.
If the cervix was pulled to any side,
Any deviations and difficulty in visualizing the cervix. That is important. Why it is important? Deviation and any difficulty in visualization of the pulled up, something like that.
if
Can
it
be
is an
associated
irregular mass, irregularly enlarged mass, then to one side, then there'll be deviation of the cervix, ma'am.
Okay,
So
that
we'll be able to.
as a clinician, how will
We can suspect malignancy.
no.
Whether it is anterior, posterior.
Retroverted or antiverted, we position
All
versions of
this becomes important when you are doing a endometrial sampling or a biopsy. So if the cervix is pulled up or deviated, what happens? There will be a difficulty. You may post the case, but getting into the cavity becomes a challenge that you will have to counsel her. There could be a difficulty, and sometimes you attempt, but you cannot enter the cavity. So visualization of the cervix is very important.
Yes, ma'am.
Any deviations are important points because you anticipate difficulty while doing a sampling. Otherwise, you don't counsel her and you take her to the theater and you do nothing and they bring her out. You have not told her in the counseling. Understood?
Yes, ma'am.
So whether it's easily visualized, any deviations have to be noted. That's an important thing because it's a huge mass.
Yes, ma'am.
Okay.
And firm in consistency, non-tender, and uterus enlarged to 18 to 20 week size with irregular surface, firm in consistency, non-tender, and phonesis free. No phoneal tenderness. Transmitted
Mass is not felt through any of the fornices. Such a huge mass. Difficult to. It has to be felt through at least the anterior fornix. Partially in the lateral fornices. It is difficult for me to believe that a huge mass of this size and fornices is simply written as free. If I was the real examiner there, I would have cross-checked your finding. I would have done the pelvic examination and seen whether any of it's occupying any of the fornices. Okay, never do such mistakes.
Okay,
So
ma'am.
fornix should be palpated because definitely this mass is arising from the pelvis, you said. So and it fell through the anterior fornix.
Anterior fornix. Okay, ma'am.
And at how I don't know the width and how broad it is. So depending on that, it will be fell through one of the lateral fornices also.
Okay.
Okay. So I suppose there is a fornicial tenderness.
And we have to rule out any chronic PID or chronic ectopic.
Chronic ectopic. See, this is a case of leiomyoma. What are the associated pathologies in leiomyoma? Common
Degenerations, ma'am.
leiomyoma, we already discussed. Pelvic endometriosis is an associated pathology with leiomyoma. Why are you taking ectopic here?
Endometriosis.
Pelvic endometriosis is an associated pathology, isn't it? Says the fornicial tenderness is positive. What do you think?
In PID or endometriosis?
Pelvic endometriosis.
Pelvic endometriosis or PID?
Associated pelvic endometriosis. Then how do you interpret this finding and how it will help you in the management? Fornicial tenderness is there. That means there could be an associated pelvic endometriosis. How would you interpret this in your management? How does it? Okay. In this case, you will not go for a vaginal approach. Understood? Tell me, when do you decide the vaginal approach? How do you make a decision for a vaginal approach?
If it is
not associated with any other pathologies,
Not any other.
Clinical assessment.
Don't say any other. Adnexal pathology.
adnexal pathology.
Okay, one
and
is
its size is less than 12 weeks, 12 to 14.
that is all experience. Some people can go up to 16, 18. That is variable. One is adnexal pathology. Then
Know his previous history if you suspect adhesions.
tenderness and nodules in the pouch of Douglas. Again, there is a difficulty. So be very specific.
Yes,
Okay. And as I said, if the width is more and the fornices, you feel the mass through the fornices. That is a case you cannot attempt a vaginal approach. Okay.
Okay, ma'am.
Right. Mobility. Okay.
Transmitted mobility to the cervix present and no groove sign, ma'am.
So what did you rule out by no group sign?
Ma'am, we have ruled out the ovarian mass, ma'am.
Probably it is not from ovarian. Any other to say that it is not ovarian?
Mobility, transmitted mobility to cervix.
History. Any other point to say in the history this is not an ovarian origin? Always history.
It's not associated with the menstrual irregularities.
So there won't be any menstrual disturbance, no, if it is ovarian.
In ovarian, yes, ma'am.
Is present with heavy menstrual bleed.
Yes, ma'am.
Okay.
Upper rectal examination, rectal
Body. Here you mentioned no nodules felt.
nodules felt in POD. Yes,
So
ma'am.
trying-
Ruling out endometriosis, ma'am.
Endometriosis or secondaries in the ovarian malignancies, right?
Yes, ma'am.
Both. So if this is positive, you cannot go by the
Vaginal.
vaginal route. Exactly. If the fullness is there, again, adnexal cell pathology, you cannot go by the vaginal route.
Okay, ma'am.
Okay.
Continue. Summary: a 42-year-old para 2 living 2 sterilized presents with chief complaints of heavy menstrual bleeding and dysmenorrhea for past 6 months. On examination, pallor present, vital stable. Abdominal examination reveals a mass of 18-week size arising from the pelvis, firm and consistent.
When you summarize, I don't think you're supposed to mention the chief complaint. So this is a case of 42 years, para to live to sterilized, a case of heavy menstrual bleeding for the past 6 and dysmenorrhea, secondary dysmenorrhea. Secondary congestive dysmenorrhea, because you have taken a thorough history by now. So your summary should be very clear.
Okay, ma'am.
There is no, like chief complaints, this sentence should not come. So please read out the summary properly again.
This is a case of 42-year-old para 2 living 2 sterilized, an abnormal uterine bleeding for the past 6 months. On examination, pallor present, vital stable, abdominal examination.
Now it is heavy menstrual bleeding because you have taken a thorough history now, clots and all that, 6 days, 7 days, 3 pads, all the days. So it's not abnormal now. It is heavy menstrual bleeding.
Menstrual bleeding.
Oh.
On examination, pallor
No.
present, vital.
Chronic secondary congestive dysmenorrhea.
Yes, ma'am.
Why you are so hesitant to say that? Don't say, I don't think we can accept like this summary on examination pallor. So with anemia, vital stable, anemia. You should say there is anemia.
On examination, anemia is present. Abdominal examination reveals a mass of 18-week size arising from the pelvis, firm in consistency with side-to-side mobility and non-tender on palpation.
Regular, right? You said the surface is
Irregularly enlarged, ma'am.
that you have not mentioned here. What does it convey to you?
If it is irregularly enlarged, it is more in favor of leiomyoma, ma'am. Whereas it is globular, uniformly enlarged, it is more in favor of adenomyosis, ma'am.
The other interpretation, irregular mass, multiple. Your interpretation is it is a case of multiple fibroids. So yeah, because you have to make no uniformly enlarged. What do you think uniformly enlarged is?
Adenomyosis, ma'am.
Anything else fibroid in fibroid? Uniformly enlarged globular. Probably it is solitary and submucous.
Okay, ma'am.
Single. Where you can think of, see, it is so important. When it is single, what do you think? What option can you give to her? If it is single, what option can you give to her?
It depends on size of the
Whatever. If it is single, one option is there, no?
myomectomy.
If it is irregularly enlarged, it is difficult to offer.
Myomectomy, ma'am.
So it is important, but you have not mentioned that in your summary. See, summary, all these points should be mentioned. Not pallor, anemia, irregularly enlarged.
Yes,
Free
ma'am.
mobile side to side, non-tender, agreed. Occupying what quadrants, that is important. You cannot skip on that point. Okay.
Yes, ma'am.
Okay, then.
On bimanual examination, 18-week size of mass arising from the uterus with transmitted mobility to cervix is present. This is a case of abnormal uterine bleeding, probably AUBL, for further evaluation and management.
Actually, in the history itself, if it is AUBL, you should also think of FIGO. What do you think? Where could be the fibroids? Based on the menstrual history, your clinical examination, all that. FIGO.
It could
Which
be
fibroid produces HMB?
Submucosal fibroids.
Submucosal fibroid, what is the presentation?
Heavy menstrual
menstrual
bleeding.
bleeding.
It can be associated with vaginal discharge.
Okay.
intermenstrual bleeding.
Okay.
She can also come with
Post-
infertility.
Spasmodic dysmenorrhea. Why infertility here? She'll come with spasmodic dysmenorrhea and uniformly enlarged uterus. So do you think it is AUB
No,
L,
ma'am.
L, O, 1, something like that? Do you think it is
No,
in
with
your
the history, this doesn't go in favor of submucous fibroid, ma'am. History and examination.
because intermenstrual bleeding, all that is not there, no?
Not there. And also it's irregularly enlarged.
Oh, so that's why the all that points becomes important. So where could be the fibroids in your case?
Could either be
Intramural. or
Where?
intramural with a subserous component.
Figoma. What are the classifications you know of in fibroids?
Ma'am, there is FIGO classification and ZW classification.
Figo, one is Figo. I couldn't hear.
I'm not audible.
What are the classifications, ma?
Ma'am, FIGO classification and Lasmer's classification, ma'am.
Anything with the European Society?
Ma'am, I'll ask them to mute it.
European classification. That is step
Step W.
Dr. Lisa,
Step
and
W
please mute. Dr.
Step
Lisa, somebody has. We'll ask them to mute, ma'am.
Step W, all that you'll have to mention. What is the purpose of this step W and European classification?
To know if hysteroscopic myomectomy is can be feasible or not, ma'am.
How many classes are there in step
To
W?
decide on the approach of.
How many scores are there in step W? How do you decide?
Ma'am, there is a score of 0, 1, 2, ma'am, for the size. Then
that is for
topography,
initial.
extent.
Once you have scored, how do you define which patient are you going to operate
If
or
it
not?
is
There are 3 grades, ma'am. 1, 2, and 3.
Okay.
If a score of 0 to 4 is there, that means it is
can be approached to hysteroscopic.
hysteroscopic myomectomy with low complexity, ma'am. Whereas if the score is between 4 to 6, it's grade 2. Then hysteroscopic myomectomy can be done, but with high complexity.
2 sittings, his hysteroscopy should be done.
Okay.
Whereas in grade 3, we'll not be able to do through hysteroscopic myomectomy.
Laparoscopy should be done.
Yeah, you're right. But you are not mentioning of those classifications. So I just asked you. So now we are thinking more of which one? Figo 3, 4, 5, 6, 7. So many are there, no? In your case.
Figo 4.
Why not 3?
3 also.
3
Also is a
Possible.
3 also possible. From 3.
3
also possible.
6 possibility. Because you're able to feel, no? Irregular. From 3 to 6, it is a possibility. Isn't it? So what is the further evaluation and management you want to do?
Blood.
Ma'am, then
We
I'll do blood investigations, ma'am, like CBC, peripheral smear, then RFT, then ultrasound.
What ultrasound?
We'll do ultrasound
the transvaginal.
abdomen and pelvis, ma'am.
Abdomen
Pelvis.
is okay. So what do you find? What do you expect in this case?
Ma'am, we can we can expect low hemoglobin, ma'am, for which anemia correction has to be done.
What type of anemia you expect?
Iron deficiency,
So what is another important relevant investigation you want to know?
serum ferritin, ma'am.
Yeah, serum ferritin also has to be done in this case. And then
And then we have in USG, we can expect
how do you
hypo-
Information you want to know from the ultrasound.
what are the different describe how what are the findings, how it should be, nowadays they say the radiologist have to define and give a report as per MUSA.
Yes, ma'am.
Yes, ma'am.
Yeah.
So the size, site, and the number of the fibroids have to be mentioned in the ultrasound, ma'am.
No, it is not like that. It's a systematic report has to be generated. First is the uterus size, as you rightly said. So what are the size? Like size means the length, anterior posterior diameter, and transverse diameter. I'm telling you again and again. The transverse diameter is very important because it gives you a decision whether to go vaginally or not. And then lastly, the volume. Nowadays, we are talking of volumes. Okay. Calculation of the volume of each fibroid has to be mentioned. Okay. Then systematic way you describe.
Endomyometrial junction.
From outside in, still we are at the serosa. The contour, as you said, whether it is regular, the serosa is regular or it is lobulated. So going from out to in now. We talked about the dimensions. We talked about the volume. We are talking about the serosal contour, whether it is regular or lobulated. Then after the serosal layer, what comes next after this?
Mine.
Myometrium, right?
Ma'am.
Myometrium. Myometrium, whether it is symmetrical or asymmetrical. Where do you find asymmetrical?
In fibroid.
adenomyosis, ma'am.
Fibro?
Leiomyoma.
No, asymmetrical.
Asymmetrical, we'll find it in adenomyosis, ma'am.
So that's why it is important. Symmetrical or asymmetrical. Then next, echogenicity of the myometrium. Homogeneous or heterogeneous. Then
The
margins of the lesion. Ill-defined, ill-defined. And then so many things in the myometrium. Then
endomyometrial junction.
location. Whether it's in the first, right lateral wall, left lateral wall, posterior, lower body, cervical, location. Then comes your junction. Endomyometrial junction. Then next, after the junction,
Endometrium.
endometrium,
Endometrial contour.
okay,
Endometrial
thickness, and distortion. The cavity is distorted or not. So many findings have to be mentioned by the radiologist. If they don't mention, we should ask them specifically. The mapping of the fibroid is very important. Then Any other investigation?
We can also do
MRI.
You don't want a Doppler? Direct.
Yes, USU Doppler.
So
In fibroid, peripheral vascularity will be present.
okay. In adenomyosis,
Intralesional vascularity.
translesional. Okay, 3 types of vascularities, no? Circumferential, translesional, intralesional. Okay. And then after the Doppler, any other you
MRI.
think is superior?
MRI.
We can do MRI.
How about 3D?
3D ultrasound.
That is equivalent and superior, almost as superior as the MRI. What are the advantages of MRI? Repeatedly, you are saying MRI. Why you wanted an MRI? What is the superiority?
We can
rule out malignancy, ma'am.
We can also differentiate adenomyosis from fibroid clearly, ma'am.
Okay. Any other advantage?
Pressure, urine.
Hydronephrosis.
Very small in size, because they say less than 1 centimeter usually is not picked up. So one factor we'll have to counsel them, no? Recurrence, especially when we are going with conservative. So fibroids as small as 1 centimeter can be picked up with an MRI. That's another advantage, especially when you're going with conservative management. Okay, tell me something about MRI, because repeatedly you're so fascinated about MRI. Description.
There is a MRI guided
That's an investigation.
focus.
Investigation modality.
T1 weighted, T2 weighted, and what is the
Other one.
because you were so fascinated, or MRI.
Hyperdense.
How do you describe the lesion in ultrasound, CT, MRI, echogenicity in ultrasound, MRI? How do you describe it?
Hypointensity.
Intensity or density?
Hypointensity.
Huh?
Signals, high signal, low signal, something like that. Another importance of MRI.
If you're planning for MR HIFU.
Okay. Any other? If you have chosen a conservative method called uterine artery embolization, if you have chosen the embolization, you want to follow it up, no? To regression of the size.
MRI.
So you go, the follow-up is always with an MRI. When you go with a conservative management. Okay. So sarcoma, you have been telling that one of the advantages is sarcoma, no? Diagnosis of sarcoma. So clinically, how do you suspect? What is the incidence of endometrial cancer actually associated?
0.5 to 1%.
Endometrial cancer is associated in leiomyoma.
0.5 to 1%.
0.5, I don't know. Textbook of Shaw is given as 3%, even T-land, something like that only. 2 to 3% they have given. Endometrial cancer. But whereas leiomyoma sarcoma is very less.
Okay.
The incidence which you are telling is correlating with the sarcoma, not
Sarcoma.
sarcoma. So endometrial cancer, how do you say, menstrual history, how it would be? If it is sarcoma, how would be the history?
Rapidly grown fibroid, rapidly increasing size. It will be with pain,
degenerative changes associated with it.
What are the other causes where there will be a rapid increase in size of the fibroid? What is the normal growth of a fibroid?
0.5 centimeter per year.
0.5 centimeter per year.
Yes. Per year, yes, ma'am. 0.5 to 1 centimeter per year.
Okay, 1 centimeter per year. So rapid increase in size happens in leiomyoma sarcoma. Any other condition where there is a rapid increase in size?
Infections, degeneration, or any hemorrhage.
Infections, no. Pregnancy. One condition where there is a increase in size. Okay.
Ma'am. Hello.
8 o'clock. So pregnancy, COCs, as you said, red degeneration, these are some reasons, no? Apart from sarcoma. Okay. How do you suspect sarcoma when you're operating?
Age of the patient is important, ma'am.
Yes, agreed.
Then serum LDH is important, ma'am.
Okay.
And MRI findings also are important, ma'am.
Yes. And then in the specimen, what are the features?
What is the
Necrosis.
color, texture, consistency?
Liquefaction, soft.
Soft.
What about the world appearance? I mean, will it be preserved?
It will not be.
What will be the color?
Gross appearance of the specimen, cut section, even before
Yellowish.
Capsule.
normal fibroid, benign one,
World
consistent form, no? Form with appearance,
World appearance.
well circumscribed, and the pseudocapsule, all that is lost, right? Becomes grayish, soft, necrosis, hemorrhage, loss of world appearance, and then the capsule. There's no pseudocapsule. So many changes are there. You never read about it? Cut section. Line of action, plan after ultrasonography, 3D and all that. Doppler.
We have to first we have to give medical management, ma'am.
What
But
medical?
actually, if the size is more than 12 weeks, we will have
What
to
will
go
you do
with
for your
surgical.
patient? See, your case is 18 weeks, right? What do you want to do for your patient to please tell?
Ma'am, I'll go ahead with
She is 45 years.
surgical management, ma'am. She has completed family.
Biopsy, histology is not important. I'm really worried from the beginning because you said she did not respond to the medication. That is the worrying factor I have from the beginning. I told you that is one of the criteria to rule out endometrial carcinoma. Directly hysterectomy without a histopathology is not at all correct. She has heavy menstrual bleeding and responding to your medication.
Yes, ma'am.
Why you-
Endometrial sampling, we have to send for histopathology, ma'am. And
No.
also
What type of endometrial sampling? What is the thing you want to do? You want to post her for a hysteroscopy? You want to plan for a office procedure, or you want to do a DNC? Which one?
Fraction DNC.
Have you mapped the myoma? Have you done a mapping?
Mapping should be done in case of multiple fibroids.
Not on multiple, in every case of myoma, mapping has to be done. Just not be, it is multiple, any case. So which type of biopsy you want to do? I was asking you.
Hysteroscopic.
Why do you want a hysteroscopic guided biopsy? Why not a DNC? Why not a people biopsy? Why you're preferring
People's biopsy false negative rate is higher. If you suspect malignancy, it's better to do DNC or hysteroscopic guided.
If the
See, she's
Sorry?
in, you want to post her directly for a biopsy? You don't want to correct the anemia?
first we have to correct the anemia, ma'am. So
How do you want to correct the anemia? Say, suppose, because she's symptomatic, it must be, she will be 6 grams or somewhere 7 or less than that. Because she's symptomatic.
considering her status, she might need parenteral iron or blood transfusion, ma'am.
Okay. Say, suppose she develops a transfusion reaction. You've given her Paxils and she developed febrile reaction. How will you manage? It happens, right?
Yes,
Pause
ma'am.
there, yeah.
GNR,
You have to correct anemia, right? So
GNRH analogs,
So how do you think
GNRH
the
analogs,
various drugs you have to control the, correct anemia? GNRH,
GNRH analogs,
analogs. What are those analogs? What two types, right? Agonists and
GNRH agonists and antagonists, ma'am.
which is better? Which is faster? What is the advantage?
Immediate action, antagonist is better.
Name one or two antagonists.
Elagolics.
Tetrorelics.
So why it is superior to agonist?
There will be no flare up in antagonist.
Initial flare. Okay.
Initial flare.
Okay.
Oral drug is available in elagolics oral supplement, ma'am.
Elagolix is superior or relagolix? Which one is superior?
Elagolics.
No, it is relagolix. It has been proved to be more superior than relagolix because there are a lot of side effects, not very effective relagolix when compared to elagolix. So what is the new drug which is coming up in the market now? Relagolix.
Relevance. Okay.
Oral GnRH antagonist. What is that fixed drug combination that they are trying to bring into the market, which is FDA approved now? How much of GnRH antagonist it has? Dosage. 40 milligram. 40 milligram of GnRH antagonist with 1 milligram of, because in our institute we have taken up this study. We are trying it on 12 cases, 6 with the GnRH luprolide injectable and 6 women on oral. 1 milligram of ethinyl estradiol and 0.5 milligrams of non-ethindrone. Why this combination? That's why I said this is superior. Relagolix is superior to elagolix. This is a fixed drug combination. So what is the advantage of adding this ethinyl estradiol and norethindrone? Why this combination?
bone mineral
Reduces the
density.
side effects, ma'am. It's like an add-back therapy.
Yeah, to reduce hypoestrogenic side effects, ethinyl estradiol. The role of norethindrone, progestin,
To regularize the bleeding.
Reduces the volume,
To reduce the
fibroid volume.
unopposed effect of estrogen.
Not the volume.
Bleeding.
Hmm. So what advantage of this oral? One is reduction in bleeding and then reduction in the size. Because volume also will reduce, no? What is the advantage of reduction in the size of the mass? 18 to 20 weeks size.
We
Apart
can
During surgery,
advantage.
the approach
Exactly, because she had 2 vaginal births instead of
we can reduce the size and we can do a vaginal hysterectomy, ma'am.
yes, that is one advantage. So any other way of correcting anemia? Any other way? You said blood, you said parenteral, you said GnRH, injectable, you said antagonist. Any other?
Ulipristal, ma'am.
Okay. What is ulipristal?
It is a selective progesterone receptor modulator.
Have you ever used it? Any experience?
No.
Or some kind of concern?
what is the major concern with ulipristal?
Liver toxicity, ma'am.
So what is the dosage? What is the mechanism of action?
10 mg ulipristal
Daily
is the
for
dose.
What is its mechanism of
3
action?
months.
Basically, what category of drug it is?
Anti-progesterone.
Selective progesterone receptor
Selective progesterone
modulator.
receptor modulator.
Hmm. Okay. So what is the trials are there, na? Pearl 1, 2, 3, 4. Tell something about the trials in relation to ulipristal. Pearl 1, Pearl 2, Pearl 3, Pearl 4. What do you understand from those trials? Yes? Pearl 1 is they just studied about the efficacy of ulipristal, 5 mg and 10 mg. So what did they do in Pearl 2 study? You know, you don't know. Yes? So it was a comparative study between ulipristal and luprolide.
Are you there, ma'am?
Where what is it? Pearl 3 and Pearl 4?
Side effects.
No. Extended use with norethistérone. They wanted a definitive withdrawal bleed because 3 months you give the medication and 2 months off, right? Waiting for the spontaneous menstruation, they didn't want to wait. So they have started using norethindrone so that there will be a predictable withdrawal bleed. Extended use was in 3 and 4 Pearl study. So the concern is liver toxicity. So how, if at all you have decided to give ulipristal, wonder drug, so how will you give?
Serial LFT monitoring, ma'am.
Serial means?
How frequently?
And first, at the beginning of the therapy, we'll have to do a LFT.
Baseline.
After 6
Call it
months,
as a baseline. Okay.
baseline. And after 6 months, ma'am.
6 months. It is 12 week
That
treatment.
long?
12 weeks.
So you take a baseline and then during the treatment, that is somewhere in between 1.5 months and immediately after the stopping. So 3 times LFT has to be done. Any rise of liver enzymes, you must immediately stop the medication. So reduction in the size by the medical management is something we'll have to know. Any other medication was tried?
Can give danazol, ma'am.
No, Danazol is no longer
Mifepristone.
mifepristone, Ru486. Yes, that is one more drug which can be tried. Okay. Then after the medical management, correction of anemia, then what is your next plan? Then endometrial biopsy, histology. Okay, then
If it is benign, we will go with definitive treatments.
what treatment?
Definitive treatment like myomectomy and hysterectomy, but in this case, since the woman, it is an 18-week size fibroid, irregularly enlarged, and she has completed her family, we can go ahead with hysterectomy.
Root? Only hysterectomy or anything else?
Hysterectomy with bilateral salpingectomy.
Why do you want to go with bilateral salpingectomy? You're right, but why?
Why are
Reason?
you moving the salpings? What is the recent concept?
Picks future
Is
CA
it a preventive aspect? Preventive? What?
ovarian CA, from the tubal
The fallopian, the tube and the ovarian epithelium, they originate from the same.
Yeah, fallopian tube carcinomas.
Yes, ma'am. Peritoneal carcinoma, everything originates from the same. Ma'am. So that's why we have to go ahead with bilateral salpingectomy.
How about the ovaries?
Since she's 40-year-old, we can preserve if it is healthy.
If the ovaries are
intraoperatively.
healthy,
Only the age you consider or anything else you consider when you want to remove prophylactically the ovaries?
also her family history we will have to take into account, ma'am.
So important is the family history. Otherwise, 60, 65, why to remove the ovaries? It is just not 40, even 60 you can retain. One is family history. Okay. Anything else which will make you decide that ovaries has to be removed?
Any other adnexal pathologies or anything, then also we'll have to.
Any other means?
If the ovary is healthy, like ovarian cyst and all, if it is there, then we can do along with them.
Like
Simple.
endometriotic cyst.
Independent
Why
condition?
you want to remove the simple ovarian cyst? Only cystectomy you can do. So in the beginning only we have said no associated pelvic endometriosis.
Yes, ma'am. Endometriotic cyst or any
Endometrioma.
Endometrioma, pelvic endometriosis, then you decide to remove. Otherwise, there's no need. Isn't it?
Yes, ma'am.
Okay, she's just 42 years and isn't it? She's 42, I think. Yeah.
Yes, ma'am.
So that is how you decide about whether the ovaries have to be taken out or not. Okay. Then any other imaging modality which is coming up now to differentiate between fibroid, adenomyosis, especially when you're planning a conservative type of management. A recent modality, some of the centers started doing. Because it's helpful for not only mapping, but also for the surgeon to understand whether it's going to be easy surgery or difficult surgery. And all the time, malignant sarcomas to be ruled out, isn't it? So one more imaging modality is coming up. It's being started also in Telangana, some of the corporate centers. Heard of it? What is it?
Yeah.
To differentiate from adenomyosis, to also to differentiate from sarcoma, and also for the surgeon to know how easy, how difficult the suturing will be. Elastography, the stiffness. So elastography is something, a non-invasive imaging technique that's being used. Power Doppler and elastography. Okay, all firm tissues, they're said to be looking blue. And so which tissue is going to be more blue in color, adenomyosis or leiomyoma? Which is more stiff?
Leum.
Leiomyoma. It is adenomyosis. Very difficult. Focal excision and then suturing becomes very difficult, right? In adenomyoma, focal adenomyoma. So the blue, the dark blue, it is the more stiff is the tissue. So blue indicates the stiffness. That is being used especially when they are doing conservative surgery. So have you all seen any difficulties happening while operating on such huge fibroids? Whichever the route is. Have you all seen any difficulties? If so, what are they?
There will be distortion of the anatomy
Okay. So,
and
which anatomy? Distortion of which anatomy?
Ureter and
Where is the fibroid arising from?
uterine anatomy.
So mass arising from?
Smooth muscle.
Arising from pelvis.
Pelvic anatomy.
So what are the structures involved?
Distortion of ureter course.
Bladder, mom. Pelvic.
Bladder.
Bladder. I've seen some people opening the bladder also. It is not in its normal place. It gets pulled up.
Pulled up, yes. We have seen many times now because of compression.
It is not in the pelvic. It becomes like an abdominal organ and then they just give a nick in it. So bladder is at risk. It is not in its original position. Then what happens to the ureter? In which type of fibroid it gets distorted, dislodged, distorted, and
subserosal fibroid.
subserosal.
Broad ligament.
Pedunculated subserosal or broad ligament, cervical, lateral wall cervical fibroid.
What happens? It moves medial, it moves lateral. What happens?
It moves laterally, ma'am.
Where? Which fibroid it moves?
In pedunculated subserosal fibroid, it moves lateral, ma'am.
Pedunculated nahi.
Subserous goes above, ma.
So you have to tell the location, right? Whether you're talking about the pseudo broad ligament fibroid or a broad ligament fibroid, which one you want to talk about?
Imagine
Broad ligament.
what is the relation of the ureter if it is arising primarily in the broad ligament? What is the relation with the ureter when it is arising intramural?
If it is arising from the broad ligament, the ureter will be medial, ma'am. Whereas if it is a pseudo broad ligament, the ureter will be lateral, ma'am.
So all that anatomy you'll have to know. Otherwise, so how do you prevent that injuries? Ureter injuries. Ureter related injuries.
We have to localize. We have to localize the ureter by opening the broad ligament.
Initially, we were talking about it. There are a lot of ways. Yes.
Stenting.
Okay, stenting. That does not prevent, it only helps you to identify. But prevention, again, you will have to do something, no? Always stay
Near the uterus.
the capsule.
From the
Because they're not only distorted, they'll be stretched on the capsule. So you'll have to stay within you should stay within the capsule. Before identify, feel, and then only cut. Okay.
Okay.
And what more your complications are anticipated when you are operating on such a big fibroids?
Increased bleeding, ma'am, because of the vascularity, increased vascularity.
What are the different methods of reducing the blood loss?
They can do tourniquet intermittent clamping, and also vasopressin injection, ma'am.
Where do you apply the tourniquet?
We have to make a hole in the broad ligament, and you have to compress the uterine artery
Compress
Where?
where?
near this
Do you apply on bilaterally,
Yeah.
Monica?
No, ma'am.
bilateral bilateral tourniquet.
Which part of the uterus?
Is near the
Lower? Where?
uterine
Where does the
artery.
uterine enter?
Near the internal os, ma'am. 3 centimeter, 2 centimeter lateral to the internal os.
What is near to the internal os? Down anteriorly. Which spreads?
Lower uterine segment, UV fold.
Anteriorly?
UV, lower uterine,
Yeah.
bladder. Bladder or lower uterine segment.
So you have to separate the
We have to separate the bladder and we have
fold
to
of
push.
peritoneum and push the bladder down, ma'am.
apply the tourniquet. Mhm.
Bonis clamp. Have you seen the Bonis clamp? It does that kind of clamping at the level of the internal.
Internal os. Yes.
Have you seen? Not seen. Okay. So another, you said is vasopressin. So how much drug you take? What is
20
the,
international units in 200 ml NS we have to mix, ma'am.
okay?
And
What-
just before
What is the precaution you'll have to take?
it causes sudden
It causes side effects are sudden hypotension, pulmonary edema.
How
Red-
does it act?
Before injecting, what will you do? Make sure.
we have to withdraw arterial, we should
Okay.
not go.
Aspirate, no?
Aspirate.
Aspirate it, ma'am. We should
Should
not inject it arterial.
Will
And
you
it-
inform the anesthetist?
Ma'am, not audible, ma'am.
Yeah,
Will
you'll
you
have to,
inform the anesthetist?
Yes, ma'am.
We have to inform them.
why do you want to inform the anesthetist? Why do you want to alert actually the anesthetist?
Sudden hypotension, sudden pulmonary edema will happen if we inject intra-arterially.
Coronary spasm, tachycardia, hypotension. So he has to be ready with what drugs. You alert him so that he'll keep a eye on the and then keep the drugs ready. What drugs he'll give if at all this happens? Otherwise, she'll go to cardiac arrest.
Adrenaline.
Atropine. Atropine. Then non-epinephrine drip. So we'll have to withhold and wait for how long? What is the half-life of the drug?
Can you do the procedure very slowly? So what is the time duration the drug will act upon?
Half-life. Half-life will be only 15 to 18 minutes and total. Oh,
Because it's live stream, they want us to finish by 7:45, ma'am. Sorry.
time is up.
Yes,
Okay.
ma'am. Until 7:45.
Okay.
Minutes, ma'am.
Okay. Now you're sending it for histopathology, ma'am. Isn't it? So somehow we have successfully done without an hemorrhage, without injuries and all that. Now, what is the thing you will do? Still that fear is there. No, everybody wants to ask you, even the attendants, is there any cancer? Is there any sarcoma?
Frozen section.
Frozen section. Okay. And then The gross examination is very important for what we have described. And then
Cut section.
routine histopathology or something else you can do nowadays, because we cannot take that risk, especially in fibroids, very huge ones or suspicious or borderline. What is the investigation you want to do and say we have ruled out sarcoma or malignancy? Now routinely we are sending immunohistochemistry. Okay. Immunohistochemistry, what are the things you will send? P53. P53 and K61, 67 antigen. These are very specific because they'll be raised. It indicates that it is very aggressive apart from ERPR, estrogen receptor, progesterone receptor, P53 and K167 antigen. So that is the final thing we'll have to send. Immunohistochemistry is coming up in a big way, right?
Okay, ma'am.
Okay. So I think you need to sum up what the points you have learned, right? Now you, both of you speak and we will listen. I'm done from my side.
In NICE guidelines, we'll have to, in dysmenorrhea, we'll have to mention about the quality of life, ma'am. And
the duration of bleeding 6 months indicated, duration of bleeding is important, and iron loss is also in the normal cycle. 10 to 30 milligram of iron is usually lost. Normal cycle is 2 to 7 days. 20 to 80 ml is normal.
In case of any foul smelling discharge PV, we have to think about forgotten pessary, foreign body, all these. Ma'am, and always we'll have to keep it like benign, infection, and malignant. Also in coagulation, to rule out coagulation defects, there's a major and minor, that also we'll have to keep in consideration.
While giving
Sexual,
sexual history should be added, and while giving methyl spas, mefenamic acid, RFP should be monitored, and NSAID should not be given in reduced platelet count. In family history, first degree relatives are highly prone, and genetic causes include BRCA genes, BRCA1 and 2, HNPCC, and Cowden syndrome should be taken in history, ma'am. In examination,
instead of just mentioning about the BMI, we'll have to tell about the WHO class of obesity, either 1, 2, or 3.
In palpations, we have to mention about the quadrant. We have to describe the, in quadrant, ma'am.
Mass is occupying which quadrants, and we have to describe about the mass in detail. The width of the mass is very important to, if we have to plan for the approach of the hysterectomy vaginally.
And in perspective examination, we have to mention about the accessing cervix visualization, and any deviation of cervix is there or not. And we have to mention about fornical tenderness. If fornical tenderness is present, because we have to suspect endometriosis where vaginal approach is not possible.
In summary, we should not mention the chief complaints, and we should also, even on examination, we'll have to be more specific in summary, since we have already taken the history and the examination in detail.
And in USG findings, we have to give by MUSA criteria, we have to follow in detail.
Standardized criteria about the size, site, contour, serosal contour, myometrium, whether symmetry or asymmetrical, echogenicity, margins of the lesion, location, endomyometrial junction, endometrial cavity, whether it is distorted or not.
Endometrial thickness. And we have to do with the Doppler, ma'am. Circumferential, three type of thing is there. The circumferential Doppler, translational and interlesional. In fibro, circumferential, and in adenomyosis, translational. 3D USG is also equivalent to MRI.
There is an upcoming investigation that is investigation like the elastography that we will have to read on. Tell ma'am. And also we have to rule out sarcoma, ma'am. So we have to keep in mind the age, LDH, MRI, and also the gross and the cut section of the specimen. They're also very important. We'll not have to neglect that. And the medical management.
And for anemia correction, we have to give oral iron or blood transfusion or parental iron or and GnRH agonist.
Ulipristal. And also we have to first, in case if we are thinking about the surgical management, we have to definitely do a biopsy, send for histopathology, and then we'll have to go ahead with the definitive management.
In antagonics, ralogolics is in GnRH antagonists, ralogolics is the best thing. And about Pearl trial, ma'am, in respect to ulipristal acetate, mifepristone is also is in current trend, ma'am. Then while detaining ovary, we have to see for family history and any endometrioma is there or not. In our trending imaging modality is elastography.
We have to also know about the immunohistochemistry markers, ma'am. ER, PR, P53, Ki67.
And while giving vasopressin, coronary spasm should be suspected, where atropine should be kept ready. THAF is 15 to 18 minutes.
How to minimize the blood loss? You only said the tourniquet, vasopressin, and anything else?
Clamping the uterine artery, ma'am. Bilateral clamping we can do, or with Boni's clamp.
We have to release it once in 20 minutes. To avoid.
Another simple way or to reduce the bleeding is misoprostol is also being tried. Vaginal misoprostol during the procedure, so that it will keep the uterus contracted and the blood loss is minimized. That's the easiest which is available with us, right? Vaginal misoprostol. So, and tranexamic acid, another drug which we are very comfortable using, right, left, center for PPH. So another drug is tranexamic acid, misoprostol, vasopressin. These are the things you'll have to mention to minimize the blood loss during surgery. Okay. So, thank you.
Thank you, ma'am.
Luck.
Thank you, ma'am.
Thank you,
Ma'am,
ma'am.
Well done.
I want to thank the TNFOG Bodhana organizer, ma'am, for giving our postgraduates this wonderful opportunity. And thank you so much, Maldi, ma'am. Wonderful discussion. And you stressed upon the importance of history taking. That's very, very basics the PGs should understand, ma'am. The coming to a provisional diagnosis before we investigate the patient. Wonderful, beautiful discussion, madam. Hope our PGs would have benefited a lot with this. Thank you so much, ma'am.
Shanti, ma'am, you want to say a few words?
Yeah, no words to say, madam. That's all. It was a really wonderful session. Was the way she took, from the beginning history through examination, and then in each and everything she pointed out very nicely the concept behind each and everything. So it is not only for this case. It should be applied for all the clinical cases, even in not only for examination, even daily day-to-day clinical practice. So the way you approach was really good. Thank you. Thank you.
The last to the student, why leiomyoma fibroids are so important? Why did we have a session today?
It's the most common cause of abnormal uterine bleeding
in reproductive age group.
Common. Second, common cause of AUB. Agreed. Second point, happens in across all the ages, ma'am. irrespective of the marital status, across all the ages. Can it become symptomatic in a postmenopausal woman?
Yes.
Yes, ma'am. If it is symptomatic in postmenopausal women, we have to suspect malignancy.
Okay. Any other reason for it to become symptomatic in a postmenopausal woman?
If she started hormone replacement therapies.
No, fibroid. One is sarcoma. Agreed.
Taking HRT, we can aggravate fibroid.
Oh. See what happens, there'll be atrophy of the myometrium. Atrophy of the myometrium. For the first time, the intramural fibroid can become submucous. So that's how it becomes symptomatic. Understood? One is sarcoma, one is another endometrial cancer. The third is because of the atrophy of the myometrium, for the first time, it gets shifted to the submucous and it becomes symptomatic. So across all the ages. Okay. Across all ages, most common cause for abnormal uterine bleeding. And the third is, why it is important, this topic?
For
Conservative management is coming up in a big way. Okay, it is not only surgical. So it is the conservative and medical management. Conservative, minimal invasive surgery and medical management. That's why this topic has become important, though it's a benign condition. Okay?
Yes, ma'am.
Okay, bye.
Thank you,
Thank you,
Malati
ma'am.
ma'am. Wonderful session, very elaborate and very useful for all the PGs. Thank you so much, ma'am. Thank you, Parimala ma'am. Thank you, Shanti ma'am,
Thank you,
for
ma'am.
your for training your PGs, and thank you, Imaya and
Nishita.
Nikshita.
Nikshita. Very nice to have you all, and you participated very efficiently, and you marked the points, answer at the end. Very good, and thank you so much, ma'am. And thank you all the PGs who took part in this program. Thank you so much. We'll meet
Thank you so
again.
much,
Thank you,
ma'am.
ma'am.
I
Thank
think
you.
we should have a part 2 with madam in the same topic. Because of time constraints, we had to finish it now. Thank you so much, ma'am. Thank you. Thank you, Sahiti and Sri Priya, for your support.